Hello and welcome to your continued video lecture on Chapter 35. In this video, we are going to discuss cancers of the female reproductive system, sexual dysfunction, and impaired fertility. What we find is that the overall cancers within the female reproductive system are quite common, especially in the malignant tumors of this system. And one of the first cancers we'll start describing is cervical cancer, and this is going to almost always be caused by an HPV infection. Now, there are over 150 strains of HPV, but 40 of them affect the genital area. But most of them are not going to pose a serious risk to our health. But like we said, HPV is almost exclusively the cause of cervical cancer. And there are two subtypes that are more predominant. We have HPV 16, which makes up 60% of cervical cancers, and the subtype 18 is going to make up 10% of the cancers. And these cause high-grade dysplasia. But it's not just these viruses that are causing the cancer. We also know that there's other factors that are going to kind of multiply within the having HPV, and that is going to include immune responses, hormonal responses, and other environmental factors that will determine the regression or persistence of that HPV infection. Now, when we look at the cervical tissue, we do have this area called the transformation zone, and this is also known as the squamo-columnar junction because we switch from having our squamous cells over to glandular cells, which are more columnar in shape, and this area is vulnerable to oncogenic effects of HPV and is going to be a more common site for CIS to develop. And we're going to talk about this a bit more and the pathophysiology on the next slide. So risk factors for cervical cancer will include multiple sexual partners, young age at first sexual intercourse, high party, which means that they have given birth to a live neonate a number of times, immunosuppression, oral contraceptives, and use of nicotine. Now, I'm going to mention this here even though I have it on the next slide, but I kind of ran out of room for pictures. But to take preventative measures, we do want to get Pap tests done, which are going to be performed every 3 years after the first time in sexual intercourse or by the age of 21, unless there are increased risk factors. Then you may want to do these tests more often, or if they have had an abnormal test. And that is when they slide a speculum through the vagina so that they can see the cervix, and they take a few cells there, and we're going to look at these cells on the next slide. So here we could see some normal epithelial cells within the cervix, and I like these images because they kind of show you the progression of how these cells turn cancerous over months to years. And what you could see is that this type of cancer is going to progress slowly. So our normal cervical epithelial cells are going to first go through dysplasia and then turn into carcinoma in situ and eventually invasive cancer. And you can see that taking place over here. So the precancerous lesion or the dysplasia that starts to take effect then is going to develop into CIN, which stands for cervical intraepithelial neoplasia, and can eventually progress into what we call CIS, which is the carcinoma in situ. And so how we progress to this is we will see that the basal cells, and these are the immature basal cells of the squamous epithelium, and in the areas where we have epithelial breaks or some type of injury taking place, we start to get immature metaplastic squamous cells, and these start to develop because of that HPV infection. And we typically see this in that transformation zone where we have the squamous cells turning into the columnar cells. Now, like we said, it's good to get those Pap tests done so that if that dysplasia is detected early, treatment is available to prevent the invasive cancer. And this can progress to invasive cancer if we don't catch it, although this progression is very slow. So typically we will be asymptomatic until it's kind of gone later into the stages. And some of the clinical manifestations that these patients may have is if it's early invasive cancer, then we'll have abnormal vaginal bleeding, persistent vaginal discharge, some pain and bleeding after intercourse, that may prompt them to go get tested and find out what type of or what stage their cervical cancer is in. And treatment is going to be based on neoplastic change, the size and location of that lesion, and the extent of metastasis. So some of the treatment options, though, could be surgery, either cryotherapy, excision, or laser surgery for anything that's precancerous. If it's for invasive carcinoma, then a hysterectomy would be done, and we may even do chemo or radiation therapy. Or if it's really progressive, there might be a radical surgery in which we perform pelvic exenteration. And I forgot to mention, since we talked about the Pap test in the previous slide, that these are what the normal cervical cells look like. And we may see that there's more cells, or they have multiple nuclei in precancer cells. And here you could see that they have multiplied extensively, are larger, have larger nuclei, or many nuclei within their cells. There are some prevention measures we can take. One of them is a vaccine. There is Gardasil, and that essentially prevents 70% of all cancers and 90% of genital warts. And there's also Cervarix. And this vaccine is given to 11 to 12-year-olds and sometimes as young as 9, but the typical range is between 13 and 26 years old. After that age, it is not recommended, and we would like the vaccine to be given before the initial sexual activity takes place. And it's recommended for males as well. Next up, we'll talk about vaginal cancer. Now, this type of cancer is rare and usually is going to be a squamous cell carcinoma, and its peak incidence is around the mid-50s. And unfortunately, it may metastasize because the vagina is a thinned wall structure with a rich lymphatic drainage. So it spreads to areas like the bladder, the rectum, vulva, or the pubic bone. As far as their clinical manifestation, they may have some vaginal spotting and discharge, pain, some masses within the groin, and changes within their urinary pattern. And we do see that there is an association with high-risk HPVs, such as the subtypes of 18 and 16 that we discussed earlier. For treatment, usually radiation therapy or surgery is recommended. Now, in these images over here, we can see some scattered plaques that were found and the progression of that. And we are using different types of staining in order to visualize this, such as the acetic acid staining or Lugol staining. Next up is vulvar cancer, and this is also usually a squamous cell carcinoma. Most often it's going to affect the area of the labia majora, but of course, as you could see in these images over here, they can affect the labia minora or the clitoris. And it's associated with HPV, increasing age, having a previous cancer, autoimmune conditions, and immunosuppression. And it could also be associated with things like HIV infections or tobacco use. And the development can be preceded with a condyloma or a squamous dysplasia. So if you see those visual changes, it can prompt you to go see the doctor. And to treat this, we would do ablation or excisional surgery, and sometimes, if necessary, radiation and chemotherapy. One of the most common types of uterine cancer is endometrial cancer, and it's also the most common gynecologic malignancy. Our images here can show us endometrial cancer. We see in this case the tumor is filling that endometrial cavity, or the lumen of the uterus really, and is even invading the myometrium here. And this is just an illustration of how endometrial cancer can also look. We can see that it's even invading that cervical canal here. And the primary risk factor is unopposed, meaning without progesterone, estrogen exposure. And so this can include estrogen-only hormone replacement therapy, tamoxifen use, and early menarche or late menopause, never having children, or if we have a failure to ovulate, such as if someone has PCOS. And this can lead to endometrial hyperplasia, where we are going to get the endometrial cells multiplying, increasing the number of cells. And this is associated with obesity because it's a source of endogenous estrogen and type 2 diabetes. We do see that this commonly happens to postmenopausal women with a peak incidence in their 50s and early 60s. It is less common than cervical cancer in young women, though. And usually they go in to see the doctor because they start to get abnormal vaginal bleeding, which is the most common clinical manifestation. They can also get bleeding in between their menstrual periods or postmenopausal bleeding, depending on where they are in their reproductive years. And they see pain and weight loss in more advanced cases. So to diagnose this, they would do a transvaginal ultrasound where they can look and measure the thickness of the endometrial tissue. If they find it's too thick, they will take a biopsy and do a histologic tissue exam. And to treat it, they can use progestin therapy for simple hyperplasias, but in advanced cases, they can do a total abdominal hysterectomy where they are going to take everything, even our fallopian tubes and the ovaries. And they may also do some chemo and radiation. Next up, we have ovarian cancer, and this is a common gynecologic malignancy with about 50% of the cases occurring in women who are 65 years of age or older. And it's really considered to be a silent disease because it's usually caught in the advanced stages. There really aren't great preventative tests that we can do to see if there is ovarian cancer taking place. So the risk is reduced by factors that are going to suppress ovulation. In addition to risk, we are going to look at this map here of ovarian cancer worldwide. And through their migration studies, they were able to find that moving from areas that had low rates of people who had ovarian cancer to an area that had greater risks of ovarian cancer increased their risks of actually being diagnosed of ovarian cancer. And so this really demonstrates the importance of these non-genetic factors. And we mentioned already that ovarian cancer is going to have high morbidity and mortality because it tends to be detected more in its advanced stages. And ovarian cancer is going to be acquired as a somatic mutation that tends to occur during a person's lifetime. And we see that these benign and malignant tumors are going to come from 3 ovarian cell types. We've got our germ cells, which means it's going to be derived from the endoderm, which will eventually differentiate into oocytes. We also have the endocrine and interstitial hormone producing cells that we find within the ovary, and epithelial cells that are going to be derived from Mullerian ducts that are going to cover the ovary and line the inclusion cysts. Most commonly, we will have the surface epithelium affected. You could see it makes up 90% of the types of ovarian cancer, and we do have these different subtypes listed here. Now, most commonly, we will see a high-grade serous cancer, and they're going to originate from precursor lesions that are going to come from those fimbriae, those finger-like projections in the fallopian tubes, and we find that it's associated with the BRCA gene, which we will talk about more in cancers of the breast. We also have the sex cord stromal tumors that makes up about 7%, and they tend to arrive from connective tissue, and they often are going to secrete hormones. And lastly, we have the germ cells that make up 3% up to 5% of the ovarian tumors. And we do see that this tends to take place more within the 3rd decade of life. And in this image down here, we can see the type 1 and 2 tumors. We see that the type 1 tumors are going to progress from our benign tumors through borderline tumors into our low-grade carcinoma. The type 2 tumors are going to rise from an inclusion cyst or coming from the epithelial tissue within the fallopian tube through that intraperitoneal precursor that then is unidentifiable and then can demonstrate the high-grade serous features. And by the way, here the STIC stands for serous tubal intraepithelial carcinoma. Now, as far as clinical manifestations, we're going to see that there aren't really any early symptoms, or they might have some non-specific symptoms such as abdominal distension. Maybe they're losing their appetite. But as this progresses and becomes an advanced case, we see pain, abdominal swelling and distension, dyspepsia, vomiting, and alterations within their bowel habits. And those are going to be symptoms that typically allow someone or make someone go to see the doctor and do some diagnostic testing to catch this. As far as treatment, surgery is going to be used in order to determine the stage and also to remove the tumor. In advanced cases, we may do a hysterectomy, removing the ovary and possibly the fallopian tubes, and receiving radiation and chemotherapy. Moving away from cancers now, let's talk about sexual dysfunction. And this is when we have a lack of satisfaction with sexual function resulting from pain or a deficiency in sexual desire, arousal, or orgasm or climax. And about 45% of adult women have some form of sexual dysfunction, and it could be due to a chronic medical condition that can affect both sexual desire and sexual function. So those can include, of course, organic and psychosocial reasonings. You could see some of them listed over here. And let's talk about some of the terminology that is used for this. There are disorders of desire, and this is the most common sexual dysfunction in women, and it does tend to increase in age. So we have a hypoactive sexual desire and decreased libido here. Then we have anorgasmia, and this is an inability of a woman to reach or achieve orgasm, and it may be linked to a lack of arousal here. Then we have dyspareunia, and this is when we have pain at any time from the beginning of arousal to after intercourse. So essentially it's painful intercourse, and this is quite common. They may have burning, sharp, or cramping type of sensation with their pain. And lastly, we have vaginismus, and this is involuntary muscle spasms in response to attempted penetration. And this may be due to some type of prior sexual trauma and fear of sex. So it's almost used as a type of coping mechanism to avoid that activity from taking place. Now let's move into impaired fertility, and unfortunately this affects about 15% of all couples and is going to be defined as having an inability to conceive after a year of unprotected intercourse. We do see that these rates are increasing, rates of infertility, because of increased rates of STIs, environmental exposures, and delayed childbearing. And we see that ovulatory disorders account for about 40% of female infertility. And so when a couple is going through the inability to achieve pregnancy, let's say, the initial workup is going to include semen analysis, determination of ovulation, and hysterosalpingography of the fallopian tubes. So this really helps to determine if there's any ovulatory disorder, which we mentioned earlier, and if there's abnormal semen or a blockage of the fallopian tubes, which or any type of, let's say, flow of the semen to contact the egg. And that tends to take place in about 20% of infertilities, or possibly determining if there's endometriosis that can also serve as a blockage, or maybe inability to implant on the uterine wall. So for treatment, we are going to aim toward correcting the problem if we're able to identify it, or maybe the couple decides to go through assisted reproductive technologies, or ARTs.